Okay, hi everyone. My name is Lauren Sarembock. I think I've met most of you, but for those of you who I haven't, I'm one of the MOs working in POPD. And today I'm going to chat to you guys about headaches in children, and especially an approach to headaches in children in the ED. So just wanted to start with my first slide. Unfortunately, I can't claim that my patients drew these pictures. I stole them off the internet. But I just thought they were pretty cool. Kids often struggle to describe their symptoms, especially the younger ones. So I thought this was quite a fun way of getting them to describe their headache symptoms. And sometimes can actually help you come to a diagnosis if they have really good drawings. So like I think that one at the bottom of the train, to me, looks very much like a cluster headache. So that was a fun way to start. Okay, so just to start talking about how common headaches actually are in children. So the simple answer is vary. By about age 18, about 90% of children will report having had at least one headache. 1 in 5 children have recurrent severe headaches, and 3% of children have a chronic daily headache. And to put that into perspective, what a chronic daily headache means is it's having at least 15 days out of a calendar month where you can record a headache. So that means basically every second day, a child has a headache. So I just use that little picture at the bottom to basically show that in an average class of about 30 children, one child will have a headache every second day. So that's really significant. So whether you're working in the ED or POPD or any sort of environment, if you're interacting with children, there's a really good chance that you're going to see kids that present with headaches. So the good news is, even though huge numbers of kids experience headaches, only the minority will have a headache that is life-threatening and that requires urgent diagnosis and management. So now our job is to find those patients, and it can be quite tough because, like I said, you might have many children presenting with the symptom, but very few of them need urgent management. So we now need to dig through the cases that we get presented with and find the ones that need to be addressed very urgently. So anyone who's an Agatha Christie fan like me will recognize the famous detective at the bottom of the screen. All right, so now how are we going to do this? How are we going to wade through these huge numbers of children presenting with headaches to find the ones that we need to address urgently? So the good news is that not all headaches are the same. So fortunately, there's a classification system that we use to try sort of organize headaches into different groups. And by doing so, hopefully help us to diagnose the type of headache and therefore what sort of management is required. So this is just an example of a few different types of headaches. I'm sure many of you will be familiar with some of them, but there is quite an extensive list available. So when we talk about classifying headaches, there's something called the International Classification of Headache Disorders, or the ICHD, and it's in version number 3. And it is an exhaustive list of headaches. So if any headache you can think of is on this list, including ice cream headaches, or what we like to call brain freeze. And it's a very handy way to basically classify headaches. And also it has the diagnostic criteria for each type of headache. So if you're worried that your patient has a migraine or a tension headache, or any other type of headache, you can use this classification. It's available online, and it helps you with the diagnosis and helps you to classify it into one of these 3 groups we're going to touch on today. So a primary headache is the one group, secondary headaches, and then neuropathies and facial pains, which we're not really going to talk about today. All right, so let's start with primary headaches. So primary headaches are by far the most common. Fortunately, they're benign, they're self-limiting, and we usually make the diagnosis based on the symptoms. So the 3 main types of headaches that you're going to see under the primary classification are tension headaches, migraines, and what we call the TACs, or the trigeminal autonomic cephalalgias, which the most common and widely known one is the cluster headache. So just to go through them briefly, tension headaches are the most common out of the 3 types. Classically described as a tight band or like an elastic band around the forehead area, sometimes radiating down to the neck. It's the least severe of the 3 headaches. Patients will often complain of mild to moderate discomfort, but usually they can continue with their daily activities. Migraines are typically felt unilaterally, and it's usually in the temporal area. patients often describe it as being a sort of a pounding headache, or like a drum is beating in their head. Children have a bit of a unique feature in the way that they can often feel it as a bilateral temporal pain. So just be aware of that when you are taking a history from a child. It is a little bit different to an adult. Migraines are usually more severe. Patients often have to stop their activities and go sit in a quiet, dark room. They often become quite sensitive to things like noises and lights. So I often find they have to go sit somewhere quiet, dark, until the headache resolves. And then lastly are the TACs, which are the headaches that are associated with autonomic features. So, like I said, the most widely known one is the cluster headache, which is classically a headache felt within the eye. It's the most severe of all the three types of headaches and can be debilitating. Generally, it's also associated, like I said, with autonomic features. So cluster headaches, for example, will be associated with ipsilateral tearing, and yeah, just general sort of discomfort of the eye. Sometimes also rhinorrhea as well on the same side. So those are the three main types of primary headaches. And like we said, they do differ in severity, and the diagnosis can be made clinically. Children do experience all these types of headaches much the same as adults do. Cluster headaches are quite unusual, but not unheard of. All right, so then moving on to secondary headaches. So secondary headaches are quite self-explanatory. It's a headache that's due to another underlying cause. As you can see on the screen, I've sort of taken a screenshot of the classification from the ICHD classification system. You probably can't read it all very clearly, which is okay. I just really wanted to demonstrate that there's quite an exhaustive list of the causes of secondary headaches. There are many, many categories and types of headaches, and certainly won't be able to go through all of them. But basically the underlying concept is that there is some sort of cause that we need to find that is precipitating this headache, unlike a primary headache when there is no underlying cause. So most of the secondary headaches you see will be benign and self-limiting, but unfortunately there are that small percentage that are life-threatening. And like I said from the beginning, these are the ones that we need to find and we need to diagnose urgently. So most of the secondary headaches that you'll see, especially in the ED setting, are secondary to a viral illness. A lot of kids will have upper respiratory tract infections and have a headache that goes hand in hand with that. But there will be that small percentage that have the life-threatening causes. And the most common ones we see are space-occupying lesions, meningitis, and any sort of bleed. And these are the ones that we need to find. So just to kind of summarize what I've spoken about over the last few slides, we can divide headaches into primary and secondary. Primary is when there isn't an underlying cause, and those are divided into tension headaches, migraine headaches, and the TACs. Secondary headaches are, like I said, have an underlying cause. Vast majority are going to be benign, but there is that small percentage, that little block in red, that we need to find and we need to manage urgently. So now that we know that we're looking for that little red block of patients, how do we actually find them? We basically go back to what we were taught at med school, history exam, and in some case investigations. So for all cases, it's important to do a normal pediatric history and exam that you would always do. But I just want to go through a few points on history and exam that's maybe a little bit more relevant for headache patients, and also that can indicate a red flag, which might prompt you to investigate a bit further. So in terms of history, go through all the usual stuff. Something that I learned, which I found quite useful and a nice memory aid, was this liquid faux sort of organization of things you should ask on history. So importantly, asking a lot of these questions can actually lead you to a diagnosis. So the first thing you're going to ask a patient is the location. So where do they feel the headache? Obviously, in younger kids, a lot of these questions are going to be very difficult, and that's why some of those pictures that I showed you at the beginning are maybe quite a nice idea if they're a bit more artistic. But in an older child, they should be able to explain this quite nicely to you. So where are they feeling the headache? Are they feeling it? Is it a frontal headache? Is it a temporal headache? And quality, what does the headache feel like? So does it feel like that tight squeezing band of a tension headache? Is it the pounding drum of a migraine? Is it a very sharp pain in the eye, like a cluster headache? Intensity is how bad is it? So is it just a bit uncomfortable and a bit irritating, or is it they have to be fetched early from school, or they're sitting in the corner at home in tears, it's important because it can help you with the diagnosis. How long does the headache last for? How frequently are they having the headaches? And are there any other features? So like we said with the cluster headaches, do they have tearing or rhinorrhea on the same side? Do they maybe have vomiting? Any other symptoms like dizziness, photophobia? Those can all help us make a diagnosis. And how does it affect the child's activity? So very similar to what I said earlier, but, is it so severe that they sort of stop what they're doing? They may be having fun with their friends and they stop playing with them because they're just feeling so terrible. Or is it just a bit annoying and they just come and tell mom they have a headache and then they go on with their day? It's also important to know what goes on between the headaches. So does the child have the headache, make a complete recovery, and then have another headache maybe a bit later on or the next week? Or is there some sort of deficit between the headaches? And that's really important, because if the child does not fully recover, that is very concerning. So if the child has a headache and maybe associated with some ataxia, for an example, the headache resolves but the ataxia persists, that is quite concerning. All right. Other things to look out for in history, so some red flags, things to think about when you're asking a history about headaches, is how bad is the headache? And something that they often refer to is a worst headache ever. So you get some kids that are quite used to having headaches. They have headaches every now and again, and it's not really bothering them. But suddenly one day they have their worst headache ever. So it's the sudden severe headache that they just can't shake. And that is concerning for some sort of intracranial bleed. Important to ask when the headache gets worse. So if it's worse when they wake up in the morning, worse when they exercise, or worse when they Valsalva, you've got to think of raised intracranial pressure. If the headache is worse, like we said, on waking up or even wakes them up from their sleep, or worse when they are lying down, also concerning for raised ICP. Early morning vomiting is also a red flag and something that you must ask about with headaches. Okay, so other things to note is, has the headache changed? So we spoke right at the beginning about some kids who get a headache literally every second day and they almost get used to it. So if the headaches are, sort of quite consistent and it's just normal for them and they're otherwise quite well and neurologically intact, it's much less concerning than a child who's maybe had headaches for a couple of years and suddenly the headache is very different. So the way it feels is different, the severity is different, the frequency is different. Those are all things you should kind of keep an eye on. It's a different situation to a child who's had tension headaches for the last 5 years. Another thing that's very important in children is any sort of behavioral or personality changes. In older kids, you can also look at things like school performance. So if there's a child who was maybe doing okay at school and suddenly is doing really terribly, that's concerning. Similarly, in a younger child where they're too young to be going to school, you want to look at milestones. So if you have a child that was previously able to maybe run around and now struggling to stand or struggling to sit, that's definitely a red flag. Any other neurological signs associated with a headache, something you must also keep an eye out for. So some of the things just to mention are things like blurry vision, diplopia, any sort of seizures, clumsiness, like we said earlier, something like an ataxia. I actually had a patient a while ago who complained of about a 6-month history of headaches and then new onset diplopia. So that made me quite nervous, and he actually was experiencing the headaches occipitally, which would have fitted with some sort of iron or visual impairment as well. So that made me quite worried, but we did a scan on him and unfortunately he was fine. But those are the sort of things that set, your average headache apart from a headache that you need to be concerned about. And then other kids that have chronic medical conditions. So I think children that have VP shunt, sickle cell, you've got to have a higher index of suspicion for something not, being completely normal with them when they complain of headaches. All right, so examination, you do your normal examination that you would in any child, but here are just some things to look out for. So something that we often forget to do in kids is blood pressure. Always important in a headache, just to make sure that that isn't the cause of the headache. Temperature can be important because a raised temperature is obviously a sign of something infective going on. So it might give you a clue as to whether it's something like a meningitis or hopefully something a bit more benign like a viral upper respiratory tract infection. Head circumference is important, especially in younger kids. It's not something we really do routinely in the ED, but if you notice that the child looks macrocephalic, or you do a head circumference and you see there's a really big increase from the last head circumference, that's obviously concerning for something like a raised intracranial pressure or even a space-occupying lesion. Look at the child in general, and important to take note of their mental status. In an older child, a child that is confused, disorientated, it's obviously a red flag. In younger children, they obviously can't express themselves, but you might just find the child very irritable or perhaps lethargic. Other things to look for are things like skin lesions. We see them every now and again in POPD, kids with neurofibromatosis. Recently, we actually had a tubular sclerosis, which was very interesting. And those kids, again, like we spoke about, kids with underlying disorders, with shunts, if they have a headache, you're going to think of slightly different diagnosis to a child that doesn't have an underlying condition. Important to do a good head and neck exam. It can help you with the diagnosis. So a child that presents with something like an otitis media, a viral upper respiratory tract infection, sinusitis, that can definitely be the cause of their headache. So sometimes you can make the diagnosis quite quickly and easily. All right, so something else that we'd love to do in all children is fundoscopy. Unfortunately, I can say my track record is not very good. I think it's very, very difficult to do if the child's eye isn't dilated, and especially in a setting where it's usually quite bright. Also, I don't think too many children are going to sit nice and still for you to do fundoscopy. So although it's a great tool to have, it's not always feasible. If you are lucky enough to see papilledema, that will give you a bit of a clue as to what's going on, but unfortunately it's not an acute sign. So it's, yeah, as much as it's nice to have, it's difficult to do and not maybe the best test we can do. So an alternative to that is if you get your ultrasound machine out, and you can actually measure the ocular nerve sheath diameter, and that will give you a much better idea about raised intracranial pressure. And it's also going to be a lot easier to do than trying to do fundoscopy in a bright room. Excuse me. So that's an alternative to doing fundoscopy, and probably a better and more accurate option if you have an ultrasound machine available. Okay, so some other things to look for in examination, any sort of abnormal neurological signs. So like we spoke about ataxia, any sort of cranial nerve palsies, any weaknesses, any loss of sensation, all of that in combination with a headache is worrying. In a younger child, you're going to look at the fontanelle, a bulging fontanelle, splayed sutures, sunsetting eyes are very suggestive of a pathology, either of a raised intracranial pressure or just the bulging fontanelle and the fever. Can be very suggestive of a meningitis. In an older child, you can look for meningism, so just getting the child to sort of flex and extend the neck, and if they struggle to flex the neck fully, that's something you need to be concerned about. Other tests that we like to do are things like Koenig sign, where you get the child to lie flat on their back. You get them to flex the hip at 90 degrees as well as the knee, and then you slowly extend the knee. Then the Brzezinski sign is again the child lying flat on the bed. You're going to flex the neck forward and see if the child, sometimes their whole body actually lifts off the bed, but otherwise, even if it's just the knees, that is a positive sign. And then another alternative is something called jolt accentuation. That is a test where you get the child to rapidly move their head from side to side. And if the headache worsens after that movement, then that's considered a positive sign and suggestive of meningism. Okay, so now we've had a look at the different types of headaches, as well as the different things we're going to be looking for in history and exam. So now, once you've taken a good history, you've done a good exam, you can try to figure out in this little picture where your patient fits into. So is it a tension headache? Is it a viral upper respiratory tract infection that's causing the headache? Or is it something that looks a bit more serious? Patients that don't have any of the red flags that we've spoken about don't need a routine investigation. So I just wanted to emphasize that not every patient who has a headache needs a CT scan. There are a lot of patients, like we said, who have very benign either secondary headaches or primary headaches that don't necessarily need further investigation. The ones that need investigation and need urgent investigation are the ones that have the red flags either on history or exam. So I'm not going to go into too much detail, but basically the main investigations you're probably going to be looking at is some sort of imaging. So an MRI is first prize if you're worried about a space occupying lesion or a bleed. But in our setting, unfortunately, it's quite challenging to get that, especially in an emergency setting. So in most cases, a CT will be what gets done. Meningitis, diagnostic investigation is going to be a lumbar puncture. Obviously, if you're worried about raised intracranial pressure, then you might hold on that and do the imaging first. Okay, so now what do we do about these patients? So we've spoken about how many patients present with headaches. So what do we actually do with them? So if it's a secondary headache and we find the underlying cause, you need to treat the cause. If it's a serious life-threatening cause, they'll often need referral to a specialized department like neurosurgery. If it's a meningitis, they'll need to be admitted and treated with the IV antibiotics. More benign causes like viral upper respiratory tract infections, sinusitis, those sort of things that we can obviously manage the underlying cause, and the headache should resolve with the other underlying problem. Primary headaches can be a little bit more challenging. So we see quite a lot of these headaches in POPD, and unfortunately, there's no silver bullet for these headaches. And a lot of parents that present with their children are often quite disappointed that there isn't like a magic tablet or injection or something that's going to solve the problem. So it is a three-prong approach usually. So number one is lifestyle modification. So simple things that sound so silly but really make a big difference are things like making sure the child is well hydrated, the fact that the child is eating well, so not skipping meals, not eating too much sugary stuff, not having chocolates for breakfast, making sure the child is physically active so they're getting enough exercise, sleeping, making sure the child's getting a good night's sleep, not being disturbed in the middle of the night. And then one of the hardest ones to implement, but probably one of the most important, is reduction in screen time. So there's a lot of information out there at the moment that kids these days are spending far too much time looking at screens, whether it's iPads, phones, TVs. It feels like it's nonstop. So that's one of the most difficult things to get children to stop doing, and parents often get a bit upset with that as well, because they're quite happy for the child to sit and watch TV and not bother them too much. But it's an important thing, especially before bed, that we encourage a decrease in screen time. The second prong of the three is trigger avoidance. So if there is a clear trigger that makes the headaches worse or starts the headaches off, it is best to avoid it. I know there's a lot of talk about, avoiding things like cheese and chocolate if you have migraines, but that isn't the case for everyone. So please don't deprive children of nice food unless it really does make their headaches worse. I'd be very upset if someone took chocolate away from me. So if there is a clear trigger that you find makes the headaches worse, then definitely advise that they avoid it, but don't just remove random things from the diet in the hopes that it's going to make the headaches better. And then the third prong is medication. So a lot of parents come in with the hopes that you are going to give their child some magic medicine that's going to sort of fix everything. But the reality is that it's part of the management plan, but it doesn't necessarily get rid of the headaches. So depending on the type of headache, we choose different types of medication. So if they're headaches that are fairly infrequent, not too bothersome, usually just PRN analgesia is sufficient. If the headaches are more significant, they happen very frequently, and they're really interfering with the child's functioning, then we will consider some sort of maintenance therapy. So children with migraines, for an example, we usually advise that they use triptans and NSAIDs as like a acute management plan. And then sometimes we have them on other medications as well to sort of maintain them even when the headaches aren't there. So some of the maintenance therapies of choice that we sometimes use are things like propranolol. Some of the anti-epileptic drugs as well are used. But like I said, unfortunately, it's not as simple as just popping a pill and stopping the headaches. So some children, unfortunately, do get frequent headaches, and it kind of becomes part of their life. Unfortunately, they get almost used to it. And we can't really guarantee that we're going to be able to eliminate them from their lives altogether. So we do as best we can to modify their lifestyle and give them medication to help them. But it's also important that even if they are children who have regular headaches, that they're quite aware of when they need to present. So as we spoke about earlier, if the headaches change in some way, or if any red flags develop, it's very important that the patients know what these things are so that they know when they need to present urgently. From our perspective, generally, patients need to be followed up if they do develop red flags, or sometimes if the diagnosis is uncertain. Sometimes they don't very clearly fall into a specific category. It might look kind of like a migraine, but maybe a bit of a tension headache. So sometimes you just want to follow them up to see if you can come to a clearer diagnosis. Some centers do use things called headache diaries. We do have them available in POPD. It just helps to give the patient a little bit more control over the condition. It helps them to monitor their symptoms, as well as possibly pick up any triggers. But yeah, some of the patients kind of get a bit bored and don't really fill it out too well. So like I said, in some patients, we do use maintenance therapy or prophylaxis, things like propranolol, but that's only really if it's very bothersome and if they've tried all the other methods and really haven't won. But in a lot of cases, if it's not so bothersome and it's not happening very frequently and they can control it with analgesia, we usually just advise that. We've got to remember to outweigh the benefits of whatever we're doing with the risks. Sorry. Cool. And that's my little bit on headaches. If anyone has any questions, I'll do my best to answer them. Otherwise, thank you so much for listening.